Good afternoon, everyone, and welcome to the June 2016 Community Paramedicine Insights Forum. Kevin is not available today, so it's Gary Wingrove. I'll be filling in for him as your moderator. Our two presenters today are from North Memorial in Minneapolis, and we have featured them before on their program, but over the last 2 years, they've seen some significant gains from their Medicaid ACO, and we've asked them to speak a little bit more about what they've learned over time. Dr. Peter Tange, he's worked in EMS for 25 plus years, first as an EMT and now as a board certified EMS physician. He has a BA in philosophy from St. John's University and graduated from the University of Minnesota Medical School in 2000 and did emergency medicine residency at Regents Hospital in St. Paul. He serves as North Memorial Community Paramedic Medical Director, part of a team of skilled and committed medical professionals, and appreciates being able to care for people in their homes and neighborhoods. He maintains clinical emergency medicine practice in the North Memorial system. Peter Carlson started his EMS career over a decade ago at a volunteer ambulance service in rural Minnesota. Following his education at Minnesota State University Mankato, Pete studied in Sweden and found his passion to be in EMS while performing ride time in Växjö, Sweden. I hope I said that right. Since that time, he's worked for North Memorial as a 911 paramedic, critical care paramedic, preceptor, FTO, and is currently the Community Paramedic Program Manager. He's known to steer focus groups and create innovative approaches that take shape in response to environmental and financial changes while creating optimal results. Recent projects he's completed include deploying medics to improve state and federal quality measures in respect to asthma, diabetes, advanced care planning, and overseeing a community linkage project with Chemical Dependency Treatment Center in Minneapolis' North Side neighborhood. He has a bachelor's degree in management and an associate degree in paramedicine. And so, Pete, we'll let one of you take it from here.
Yeah, thank you. And actually, really good pronunciation on the city in Sweden. So, thanks everyone for joining, and we're looking forward to working our way through kind of start to finish in our program. We'll give some overview. Gary, am I controlling slides here?
Yes, if you hover above slides, there you go.
Perfect, thanks. So there's Dr. Pete and the other Pete. And what we're trying to do is discuss a bit today about combining emergency medical services into ACO models to come up with a lot of opportunities of population management. So today we're hoping to kind of go over the who and what, talk a bit about risk models and the shift from upside to downside, and then how community paramedic and mobile integrated health involvement leads to success, especially through measurement. So as questions come up, feel free to type them in, and at the end we'll discuss a bit more. So North Memorial Healthcare, just to give some context of who we are and where we reside. I'm not sure how this is shared out, but everything is a hyperlink, pretty much every image, every icon, just to allow folks to dig into some of the other stakeholders that we work with. But we're a fairly small system for our metropolitan. That's 18 primary care clinics and two hospitals, one in a suburban area that we're sitting right now and the other one in more of the metro core. And then a large multi-state ambulance system that's working in air and by ground. And so that's kind of where we were born from. And our system then moved into the primary care division, which we'll talk about here in the next slide.
And this is the other Pete. I think important for the ACO concept is the fact that North Memorial has a mixture of employed physicians and then partner physicians and partner clinics. So we have a pretty good mix. And then we also have patients who aren't affiliated directly with our system, but with some of the neighbor systems that use our services.
Yeah, absolutely. So that 18 suddenly becomes 40 by the time you're looking at the total ACO. So a lot of potential reach. So in our launch phase, we were very specific with our application of community paramedic. Given its size, we were a 1 FTE at that point. Everything was very payer blinded. We were really just trying to get our feet under us and processes developed. And so we've been up and running. It'll be 4 years coming up in October. Feels and seems like yesterday. really built ourselves within primary care in order to work as a team-based care delivery model, so that as we're capturing folks who need an introduction to the care continuum, we're able to offer them that. And it's definitely been a strong point for our group. We were able to gain electronic health record access within 2 months of launching the program, and that took some persistence, and it really paid off as far as our ability to then measure what we're doing and build out standardized charting, which really is our equivalent to protocol or guideline. And we reside within Epic Ambulatory, and then not fully familiar with everyone on the phone or on the presentation, so if questions come up, please ask them. Otherwise, some of this will be kind of specific to the type of electronic health record build. We built out hubs for efficiency's sake so that we could slice up our large geographical coverage, and really to build familiarity with the primary care providers who, kind of even a year into things still questioned what ambulance drivers were, doing as far as follow-up. So we've really done a lot for the EMS profession as well, and being able to describe and explain who we are in the different levels of EMS. Our scheduling is all done via Epic. Initially, we had a lot of owners in that. We discovered very quickly it was best to have centralized scheduling so that nothing fell through the gaps. And so we'll kind of move into where we are today.
So I think when we think about some of our struggles and opportunities with our program, the value of what we're doing is unquestionable, essentially. The impact we've had on patient experience and helping patients transition, that part is really, we've been really fortunate to have a mix of really dedicated community paramedics, but also patients who have been really needy. We've tackled some of the high utilizing patients in our system and really been able to show some significant improvements in their health and outcomes. I think the biggest challenge, though, is how, and I think one of the program leaders or managers, the challenge of trying to quantify that value is really frustrating, but really fun at the same time because we have good support to do it. But that's been the big thing, is it's this huge impact. Depending on how we try to quantify that value, our numbers range from at least $3 of benefit up to 1.5 million, I think we heard someone say once. So I think realistically we think about probably $10,000 per patient of benefit. And we can talk a little bit about that some more. The biggest challenge after quantifying that value is having dedicated data analysts. So M&R for us is measurement and recording. We have tons of data. Again, it's in a similar way. Tons of data. It's hard to narrow it down to exactly what we want or exactly the question we're being asked by someone new. But I think we're learning a lot about how to be our own research analysts or data analysts. That connection to our Epic system has been huge, and you'd think that would make it easier to take care of people outside our system who have the same electronic record, but it's essentially some of the barriers to sharing has been a challenge. And then I think growing in a strategic and smart way, again, because we're fortunate where there's very few people, I don't think there's anyone who thinks community paramedicine is a bad idea. There's some people who question exactly how to apply it, but once people see what we're doing or hear what we're doing, everybody wants us to do something for them. And then that leads to other things like defining a lab process that works for a bariatric surgeon in the same way that works for a primary care doctor. Those are fun challenges to overcome. And as we are trying to prove our financial impact, trying to make some capital purchases is tough. So, purchasing something it's easy to buy something for a couple $100, but something bigger like even an office space has been challenging. So.
And we'll talk a bit about why the struggles have kind of coincided with, on the top line, our fee-for-service to value-based existence. As folks are probably comfortable and familiar with the accountable care organization model overall, has our introduction to integrated health partnerships, or IHP, which is essentially just Minnesota's Medicaid population. Year one, we just got to share on the upside risk. So if we did well, great. If we didn't, we were insulated. And we were one of the first 6 programs in the state to jump into that risk model, which has really grown significantly, as we'll talk about. So having Community Paramedic, at the end of the day, being able to quantify, here's how and why we need a slice of that pie that's left over. We've grown all the way to $4 million in savings last year, which is fantastic. But again, all the different team members on that care team, primary care model, are obviously interested in making sure that some of that money is reflected in their budget. So we'll talk a bit about how we've capitalized on some of these struggles and really created opportunities, which brings us into our current state. So we've seen some fairly significant FTE growth. We're sitting at 7.25 now, staffed by 11 medics, covering 2 large geographical regions here in Minnesota, one being the metropolitan and the other being our Brainerd Lakes region. We've been expanding now to different ACO, or accountable care organization partners, and that's led to trying to create interoperability solutions so that we make sure we're sharing data back and forth. We'll talk a little bit about how we actually did that with a completely different organization in our Brainerd region, Essentia Healthcare. To date, we've seen, these numbers are great, and that's, the quality of the care delivered. We've seen 2,000 roughly referrals, giving us about a 4 visit per patient count at 7,000 patients. We're still using our Epic ambulatory, which is great. If folks are familiar and comfortable with EHRs, they know that when you go from an EPCR in the ambulance world, and that's typically scanned in and kind of hidden in the background of the hospital's record, it's not very actionable, to having the words paramedic show up consistently throughout progress view of electronic health records. So that's been beneficial for our group. We're seeing good viewship of different levels of provider as far as reviewing our documentation as well. Dr. Pete came on in early 16, and then we created a dedicated management position also in early 16. So we're really trying to get a lot of momentum here this year as far as cleaning up our coding and billing and just moving as efficiently as possible. And then we also, our department has kind of jumped houses or couch surfed a little bit. We started in MedTrans, which is our 911 unit that's attached to our hospital, to move then to primary care and started to get comfortable, and now we've moved to a population management division which resides under finance. So I feel like it's a really great opportunity for us to be able to articulate and define kind of our goals, measure our outcomes, and then work directly with those who are actually building the contracts for the larger organization. And just some visuals. This is something that we have to review routinely to see who our champions as far as referrals are, see who our laggards are, and kind of seek out why it can be so imbalanced from clinic to clinic, site to site. And a lot of that then ties back to our SHAPE data, which has made a lot of federal data comes through for different zip codes, and you can start to see that social determinants are playing into this, a variety of different variables. And then we'll go out and seek information from those who aren't referring to figure out what we do to improve ourselves, because really providing the same service across the whole ACO is a very key aspect to succeeding.
And what's exciting about having the variability right now is that it allows us to compare and again come back to quantifying our value, is if we can show that the clinics who have patients assigned to them who are doing better, when those are the clinics that have the community paramedics working with them, that it adds another layer of argument about our value.
Yeah, absolutely. And we've been able to get some good messaging from the different folks. A lot of the high referral sites tend to be where we're also doing care conferences. And so really that slow growth is really beneficial if you can fine-tune your approach at each site. And into 16, we were able to see an uptick just because of different pilots that we do. You'll suddenly see a surge in hospital-based referrals. And then again, revisiting what was the purpose of the intervention, measuring the success. Right now we're in the process of determining next steps on our transition process, which we'll talk about shortly. So just simple data that we're kind of keeping an eye on to see what's what and who's where, and then each medic is assigned to 3 clinics, so we can kind of associate the referral frequency with what they're doing as well, and how they're huddling and how they're communicating. So it can be beneficial at the managerial level to know who your folks are. So some of the move into the future state is a real focus on integration into our primary care network, as we've always done, and then building out to our collaborative care partners, which is kind of a game changer as far as geographical reach, different electronic health records, different care team models. So it's a work in progress to figure out how to best strategically align ourselves there. And then moving back in with more work on our transportation division so that we can start to have more of an unscheduled capacity as well, which we'll talk about later on in addition. And then leveraging data. So, hotspotting has kind of been the talk of the town for a couple of years. It was done out in Camden, New Jersey. Atul Gawande wrote about it. It had a lot of excitement around it. And even that now has been put into kind of a more reactive approach lens. And this idea, this notion of cold spotting comes in to try and even figure out ahead of that, just rather than only worrying about social determinants in geographical areas, it's really figuring out what's available to your populations that you're serving with your community paramedic program, and then helping to fill in those gaps and layer the coverage. So we'll talk about how we're aligning ourselves with community partners to really accomplish that goal. So as we've kind of touched on, but to give a little more depth, each state is different. Each county, each city, there can be a lot of variation in the approach to ACOs. In Minnesota, they're quite popular. It's a robust 340,000 lives statewide, being covered through 19 provider systems currently. 1 in 5 Minnesotans is on medical assistance, so it's a large population. And that has to do with a different level of utilizing the federal poverty level to determine your coverage. And so in our first year, as I said earlier, it was really just pretty low risk. We were going to be on the upside, but we were also committing. Each year you're doing a different RFP, and each year you're committing to more and more of the downside risk. So as your toolkit is kind of examining, or the organization is looking at what are the different tools we've gotten here and how are we using them, really community paramedic or mobile integrated health is another chance for EMS to just be that clearly defined go-to tool for X, Y, and Z, but then understand that A, B, and C will come up. And so we've had a lot of, we've been very kind of nimble and flexible in how it is we're utilized, and it's a constant work in progress, but the measures and thresholds, which are available on that link site as well, focus on the basics as far as quality, experience, and then specific hospital quality and patient experience. So some good reading material there that then gives you the chance to build out your quality measures kind of succinctly with the organization that you're affiliated with.
And I think as the new guy in the system, it's been really reassuring, and what is really attractive to me is the commitment of our collaborative care ACO to support community paramedics versus saying, well, we're going to have some other people make phone calls, or so that the ACO has, their initial hypothesis was that community paramedicine can be what the tool that we use to achieve success, and that they've been able to see that. It's been great, and it's a great model, I think, for other ACOs interested.
Yeah, when most groups go seek out and we're really not even talking today about MSSP, which is Medicare Shared Savings Program. That's its own presentation essentially, but they're very similar in the sense that those risk groups, there's no question of whether or not they're going to grow. They're going to continue to grow at a very fast pace, and eventually a greater majority of all populations residing in healthcare systems will be associated to risk. With that comes a lot of vendor options for organizations to consider as well in terms of, share the risk with us, come in, help us, teach us. So I think being very mindful, as everyone on the call today would be interested in seeing Community Paramedic be a part of that, just being mindful of what those different systems are and the fact that we're not really on their radar yet. So making sure that, as the opportunity arises that, you've got your business case kind of ready to go, and that's something that has been really a learning curve for us, but we've also been blessed now to be associated to finance as well. So who is our population? We've seen some pretty significant growth. As you can see, in December of 15, we were sitting at risk of only 4,500 lives, and due to some expansion to our collaborative network, who has historically worked within our MSSP population, or our Medicare Shared Savings, we saw that grow to 20,000. It's actually approaching 22,000 now, and we really need to figure out, from our standpoint, Community Paramedic, how we're already touching these patients as EMS providers and where the opportunity is for either disease-specific, age-specific, or location-specific. So we'll talk a bit about that. And then as noted, it's beneficial for us to be attached to an organization that was willing and interested in going in on the ground floor, which was back in 13, and that was the 800,000 savings that you saw in the initial description of this. And then the top 3 conditions that are shared amongst this population is telling of the potential need and the intervention creation as well. So we're dealing with depression, hypertension, and persistent asthma.
So our community paramedics, the way that they're getting involved is specific to our IHP population. Is the clinics are identifying which patients may benefit from a community paramedic visit. And the whole notion of the care plan being really critical, both from a legislative standpoint and just a practical standpoint. The way we've been trying to market to our primary care partners is saying, this is a way for you to take care of complex patients in a more efficient manner and in a way that can actually free up some of your clinic time so they can add to their panels and see more people. I think, again, a critical piece of our program is the fact that our community paramedics notes are standalone and easily accessible in the electronic health record. And so the primary care providers and the care coordinators and the nurses, they know where to look for vital information. I wish our ambulance reports were as equally viewed and all the valuable information that's in there that we don't get in the hospital. But that's been, I think, just really vital to the program's success. And then we look at, we do use data sets to identify people with comorbid conditions, how much utilization they've had in the past, where they live at, who they're assigned to, who their panel is, or what panel they belong to. So trying to work with that and really trying to move into a proactive state where I think the data's great. I think the data lags enough where, I forget, in our last cycle, we had a fairly high percentage of people that were deceased but still on a list of potential CP patients. So I think we went, do we deliver flowers to those? I don't think so.
No.
But the key thing is trying to really work with the primary care docs to identify the patients who they know just by their gestalt, that the folks who are at high risk, who could really benefit. So that's the fun part about having the community paramedics integrated into the primary care network, where over the at the coffee pot or having lunch at the clinic, they can catch a patient who the doc may not otherwise be thinking of referring to us. And then because we're a connected system with our own hospital, the patients who do end up in the hospital, that's another great touch point where we get referrals, and we've been exploring that more and more with some of our specific populations or diagnosis of, can the community paramedic see the patient, be part of the discharge planning in the hospital, and then really improve the transition back to home.
So the community engagement portion of what we're doing, and this is just several of the folks that we're associated or affiliated with on the right-hand side, has been really key, because whether you're dealing with patients that are being referred by primary care or out of the hospital or any mechanism or data, really we don't want to create any sort of dependence. As you saw early on, that 4 visits per patient is hopefully going to be kind of a sweet spot. May go up, may go down, but we're really trying to determine how do we cover as much ground as possible. When you're talking about 20,000 IHP lives, in a total system, 80,000 risk lives, obviously a 7.25 FTE can only get you so far. So we have to be smart about the who and when and why. And then more importantly, we have to introduce community engaged partners early on in patient care. So the work that we're doing with these different folks ranges from health screenings, which the system sees as an opportunity to generate new MRNs or see it as attribution. We're obviously continued support within mental health clubhouses, which is a model in Minnesota that helps folks and is available for people with serious and persistent mental illness. And then care plan build out for patients going through chemical dependency. And this is a pretty unique application as far as what we've been trying to do there is really sought out a population that had been utilizing 911 for non-emergent reasons, and then root cause analysis determined that really it was a matter of not having continued primary care support. They had all been given a single visit through a federally qualified healthcare center for kind of a blessing to be able to go into a group treatment setting, but beyond that there was not a lot of support. So we actually landed a medic there 4 days a week, 4 hours a day. So 0.4 of our FTE is dedicated to making sure that we do all their mantos and do some general screenings in the beginning, and then more importantly, get them into primary care, build a care plan, and then adhere to it. And I think it's really just a result of a lot of these energies that the state has also asked for help in some pretty interesting ways, including follow-up on pertussis patients, for instance, doing syphilis, HIV, pop-up screenings. So it's been a real blessing for us to be able to work with our community, figure out where do we route patients that's going to give them a long-term relationship versus the episodic care that we're kind of bringing into their home that should be very specific to a piece of their care plan.
And this, to me, this is one of the coolest things to observe is the community paramedic working with the community partner, because I think it is truly disruptive to the healthcare system. It's moving the care out of the walls of the hospital, out of the walls of the clinic, into where people are at who are fairly vulnerable. The chemical dependency folks, they're working on getting their health back on track, addressing their chemical dependency issues, but historically haven't had an easy access to screening tests for or hypertension treatment. And it's just really cool to see the medical professional of a community paramedic being the access point and the contact for some of that care, and how the community paramedic then can navigate people back or across another system or into another service. And this part has been really exciting for me as an EMS doc to see how effective we can be in this arena.
And it's also brought our transport division, I would say, into a new light as far as being, they do a great job of engaging with the community in a variety of different ways, including events. But one example came out this weekend where we went and worked at a Juneteenth celebration, which is really celebrating the African American community, the abolishment of slavery. And so we brought a rig down, and a couple of us community paramedics and Dr. Pete and some community health workers provided free screenings for anyone walking through. And the conversations we had were fantastic because they were seeing North Memorial through a different lens. They were seeing, this community health worker profession really blossom. And then a lot of folks did point out exactly what we had anticipated, which was, difficulties obtaining food, trouble getting appointments scheduled, unsure of really how to kind of navigate the system. And so as we build these relationships with the partners that you see here, the next step to that then is getting them access into portions of our electronic health record. So again, back to the basis of our talk today is that as you build out relationships within ACOs, be it Medicare, Medicaid, or private pay, commercial pay, really finding this is where majority of the payers are going is where in the community can these services be provided at lower cost. And so finding ways, for instance, today I met with Vail Place for a period of time to get them into Epic Care Link so that they can have visual access into these patients' records as well. So a lot of things come up as you're building this, and so far, it's taken a lot of work, but it's definitely paid off. So a bit of talk on our unscheduled application, and it was intentional here that only the top is different, but we're trying to bulk up a bit as far as what we can do unscheduled. It's been, I would say, a shortfall of our program that we haven't focused a lot on how do we be an alternative response unit or how do we create alternative destination. And so we're starting to work now again with our senior leaders in the ambulance division on building out for those who are already engaged by the community paramedic group, how do we build MPIs or PIs with patient lists and indexes within our CAD system, so that we can dual deploy resource, or how do we know that a care plan for a patient who's frequently calling 911 exists and that we can start living that care plan right from the initial 911 call. And so the hurdles that we have there are the lack of us being a primary PSAP to secondary, and then also working with the EPCR so that responding paramedic units can have a point of access as well. Medic 1 out of Seattle did a great job of actually landing Epicare Link directly into their EPCR so that they're able to log in on the way to a call or when they get to a call and then see a patient's medical history. So Epic won't be changing its mind anytime soon, it sounds like, as far as building out EMS patient records. But I think we can creatively find those solutions with or without their help. And they're a lot of help to us at our specific site building level. And then also, they've invited us out for talks at UGM and things like that. But I don't think it's going to be a good idea for us to wait for them to come forward with a solution, or Cerner, or any other large electronic health record. So finding other ways to do that. And then that allows us also to engage with those who are not already engaged by the community paramedic group. And so it's aggressive identification within EMS call data, high utilization record lists, the emergency care center, using data, and then various other parts of the system, including case management and care transitions. And then also, a lot of what we did for the first couple of years and we continue to do now is really just getting the entire system, the appropriate portions of the system, familiar with who we are, what we do, and when and how to deploy us. And for us, that takes the form of a call center called Care Access. And so really making sure that the folks there are familiar with when and why, and attaching ourselves to care teams within the electronic health record so that they have that instant visibility that historically I would have told this individual to call 911, whereas now my phone rings often from that department asking, is this specific reason appropriate? And so then we'll deploy. And in the long run, that leads to reduced total cost of care, which again ties back to our ACO value-based mindset.
And I think connects too to that one of the other arms of the triple aim with opening that possibility of the patient being the actual owner of the portal and access to their records, and allowing us to help them show us what their care plan is and have them be able to articulate it. I feel like that might be the more we're working on this, the more I wonder if that's the higher yield solution than trying to get Epic, Cerner, Sanzio, and everyone else to talk to each other.
Yeah, locally, that's really taken the form of my chart, and it's kind of a pleasant to use mobile interface. So, our long-term vision would be patients actually have the opportunity to request community paramedic services, electronically via their smartphone, of which are in 80% of our pockets nowadays, just, regardless of socioeconomic status. And that could lead to more treatment performed on scene, be it by the responding ambulance or the responding community paramedic. Then the alternative destination is an area that again, our medical transportation is being more and more interested in. And the comment earlier on, lab and point of care being a barrier, it's a huge opportunity. If we can increase our ability to perform blood gas analysis in the field and provide treatment, I think it'll lead to a higher level of comfort for providers to know that there's very objective evidence-based approaches to what we're doing. So I thought it would help if we got into a specific example, because I think 20,000s and 40,000s are all elephants, and we're trying to take a bite at a time. And I think the pediatric asthma project that we're just in the process of getting started and launching, hoping end of August, early September to start actually getting into the homes. This will be kind of a nice visual of how it is we look at each population. So we would process the state data that's made available, which is both claims and treatment. So it's better and better. 3 years ago, it was always 6 to 12 months old, and now it's we're starting to get monthly. So it's really great to have an idea. As Dr. Tangi mentioned, we would run lists occasionally and realize that a decent percentage were actually deceased, and so that can be a little confusing for our scheduler and our team. So this has been great to start getting fresh data, figure out who they are, and then you can actually see projected total cost of care. And I think that's also something to really take away, is that we're in a little bit we'll show data as far as our impact on that total cost of care. But if patients are getting X amount of dollars per month, you can start to really do some easy, quick math as far as annual allocation, and then use that against your own budget and really how you deploy resources to impact that. So here we're trying to engage with our primary stakeholders, which is our pediatricians, primary care, the emergency care center, and then in-home staff. And then we'll show in a couple of slides here the geographical area, how we actually map out who and where, and it starts to give us an idea of what clinics to then really focus on and affiliate with. And then sharing outcome measurements is fantastic, because you can make the determination of whether or not you discontinue or if you scale. So just a simple high level here, breakdown of per clinic, and this is just looking at total head counts. You can see 3/4 of the way down, Maple Grove is actually the city we're sitting in. It's interesting to see that there's one patient of risk attached. And then you can see our University of Minnesota Broadway Family Medicine Clinic has 409. So this map, I think, and I apologize, the lower number here, the 1196, we filtered down further to determine that 981 of them were receiving TRT or treatment or RX medication. A lot were just associated to birth, and so those will just be simple phone calls to determine whether or not it's still a part of their life or not. Busy slide, I apologize, but I just wanted to give a visual of risk, and what we're looking at here is a series of dots that just lands on different zip codes that tells us that total population residing there, and then 314.6 is a risk score, and that's a 0 to 500, so it's obviously quite high. And then the associated clinic to that was Broadway Family. And so now we get to kind of build our intervention, and this is total hotspotting, but we get to build our intervention with that area clinic team who's very familiar with the fact that there's this issue in their neighborhood, and then start to run some data on 911 call type in that area to determine whether or not asthma is prevalent. And then we can establish some benchmarks so that as we move forward on our intervention, we know what our baseline is and which direction we're going, and not be afraid to change up what we're doing. So the intervention itself, we tend to lean towards the champions of the group and that may be a community paramedic or a paramedic or a physician. In this case, it's a pediatrician. And then Dr. Tangi is able to kind of work with all the projects to weigh in, which is a great thing for us to have. And so we'll look initially at, we have someone dedicated to the team to help run whether or not care plans are in existence for all these patients. Then we can look at cost or utilization between the two different groups to see if it trends the way we think it would, that if they have their asthma control test and they have their asthma action plan, in theory they would be lower cost. And we start to figure out, again with the limited resource, who are we going to go out and see first. And the documentation that we get into will get a little lengthy, I apologize, but I think it's really worth to emphasize that at the end of the day, this goes back to the basis, if it's not charted, you didn't do it. And I think that if it is charted, it's far more likely to create a new accountability for a different care team member, and then also to create the discrete data fields early on, whether it's in paper form, electronic form, SANS, it doesn't matter who, what, when, where, why. Just really building out early on that this is what we're looking to report on. For us, this particular application will be heavy on asthma control testing and asthma action plan. And then the community paramedic receives some additional training to be able to fill out the first 2/3 of those processes, and ultimately the final approval lands on the provider, so nurse practitioner, PA, or MD. And then we also create an access point, so whether that's 912 or just our scheduler's phone number, we're trying to really tell the patient that here are the symptoms you're living with potentially, here's how you react to those, and then here's when you call this number versus this number. Because right now in the fee-for-service as an organization, it's obviously supported to, it's still kind of valued and cheered that transports are high and that days in hospital are high. And so it's really tough to live in this ecosystem of change, but we're making sure that patients understand they can reach out to our group for their needs early on. And then again, within the health record of the different ACO partners, making sure that we're beefing up the health maintenance and hitting the other requirements. So the next 4 slides, we're going to kind of clip through, but it's just given to visualize the amount of building that takes place, which initially we did all on our own. We built all of our records, and that took there was a lot of learning involved. And fortunately, within our group, we really found that there was interest in all the different necessary areas by different community paramedics. And so I think you'll find that no matter where you're at with your groups, one of our medics just really enjoyed writing basically code. And you'll see, for example, the red highlighted text on the top there, where RFV 19064. So each of these numbers represents anywhere from 1 to 100 other numbers, and we start to be able to determine that, for the first 100 patients we saw, here's our consistent reason for assessment. And a lot of that was not done for us. So we continue to build out our documentation so that we can turn around and show our partners at the end of the fiscal year, here's the correlation of our success or our intervention. And so that's, I think, really worth spending some time thinking about and looking at. And then you'll see that this documentation has a fairly heavy medical emphasis, which our state would like to see in order to pay us. And then as we go through, it's also got a lot of simple social determinant or kind of psychosocial aspects as well, where we're trying to determine where folks are sleeping, doing the things that are tough to do in a clinic or in the emergency room. How is the home heated? Figuring out the triggers and really doing something with them. And then often with the medic as well, subsequent visits will emphasize or highlight the areas that a change needs to be made and really getting the patient to own that change, like Dr. Tangi said earlier.
And I think that this documentation piece is, again, so critical. And what is really interesting to me from the physician standpoint is as the ACOs evolve and data becomes, or pointed data becomes more and more important and valuable, I think our roles as community paramedic providers of populating the electronic record with accurate, up-to-date, and relevant information is going to be another place that we can really leverage our abilities. I think the medics, we're good at drop-down choices based on our previous experience with electronic record, and putting the right data, filling these discrete data fields. As docs, I think within a year or two, we'll start to understand how important it is to have an accurate representation of how sick your patients are by using the right terminology. I think the community paramedic is going to be able to really help the providers who embrace us do that more efficiently and more accurately. So
yeah, I would say throughout the group it's been embraced. Being able to still give a narrative and have some free text. We really encourage that free text to be at either top or bottom, fairly short and to the point, and then work off the care coordinator or the primary care provider's goal setting as something that's really tangible for the patient to see why we're coming out.
And I love the fact that, all of our community paramedics, we're been trained in facilitation of advanced care planning discussions. And again, I think that ties back to the fact that we're documenting in the medical records. So not only is it important to have the conversation, but it's important to pass the baton down the care team. And by putting it in the record where everyone else is living, it really becomes a healthcare organism that's better for the patients. And the community paramedics, I think, are recognized in our system as some of the go-to people for advanced care planning. And that's still in its infancy, too.
Yeah. So we'll kind of move into talk a bit about partners and how it's more difficult to pass the baton at times. Back to, I hate to keep using the electronic health record. We're not using it as a scapegoat in any means, but it's definitely a real big challenge to overcome if you start a process to be able to hand that off. And here you're just going to see some additional clinic systems that are a part of our accountable care organization, each of which also will bring you to their specific pages. So you go from having maybe one hospital or one EMS agency to really align with for the strategic pillars that they've kind of created for the year, to now suddenly having 4, 5, 6, and then your community partners. And it can really get overwhelming to revamp your A3 or however it is you visualize your group's future. You have to be cognizant of what other invested parties are interested in. And then geographical coverage here really drew us out another 50 miles or so, upwards 75 miles. So that's another thing to be aware of, that the first time you sit down at the table, you have to have an answer for just how far are you willing to go. And really that comes down to what's the volume, what's the purpose, what's the return. But it gets pretty hairy if you start saying no. So you have to figure out, is there another community paramedic group in that area that could be providing that service? And suddenly you're even more multi-organizational. So as just kind of highlighted, sharing the data, aligning outcomes, and then I think a good example of where we did this was with a project that we're doing in the Brainerd Lakes region in central Minnesota, which is more rural. And then in the northern portion of that coverage area, it's very rural. And so the needs will change, and the medic will call me today and say that they're potentially traveling 75 miles to see a patient, and then you have to start really digging deeper into what's possible as far as telehealth, what's possible for two-way video audio. Do we change our approach from 4 home visits for this patient to maybe 2 and hybrid in a couple of phone calls? So I think reflecting on your own area and making sure that you're just aware of it being a limited resource and how to apply it allows early discussion with ACO partners to go a lot smoother and to not promise too much, obviously. And then also leveraging technology for care conferences. With that site up there is also dealing with 14 clinics, which has a lot of miles between them. So how do we get the community paramedic engaged with the different providers? So we're starting to consider and look into adding, because we currently do care conferences at a physical brick and mortar, but what else is possible out there? And then having multidisciplinary team-based education is something that's, I would say, more likely in that area than it has been here, but we've definitely been going for it. And advanced care planning was kind of our first taste of that, getting different providers in the same room. And then now that primary care providers are receiving reimbursement with that, we expect to see kind of an uptick in folks doing it. But the community paramedic is still a vital component to help pre-visit plan, so that if your patient has 8 comorbidities and 15 medications, really only a small percentage of that is going to be super relevant to their healthcare directive. So by helping them filter it down to a digestible point where they then go to their provider, and rather than having disorganized 28 questions, they've got a nice sheet of paper to reference. And so those are the areas that we've seen success with extending the eyes and ears. So I think some data here that we've run in a lot of different ways with a pretty consistent theme of inpatient reduction, is focusing on kind of 3-month pre-post methodology and then expanding it out to even 24 weeks. And systems are kind of obsessed with, and I apologize, I just saw a question. We'll address that right after this. So trying to stay in line with the organizational goals of reduction, and the emphasis right now being placed on 30 days, but it's been made aware to us that will continue to grow, 60, 90, upwards, 6 months. So we have to be aware that we're creating an intervention that doesn't only work for 30 days. As that data continues to kind of evolve, 1 year, day 17 is a sweet spot. For a lot of our hospital transition population, 4 hours was a sweet spot. It's really interesting to see the different needs of the different folks.
And I think this slide is really important conceptually, because we can run it for any time frame and it's always the same. And that is, before a community paramedic visit, there's a certain amount of utilization. Afterwards, the utilization changes. And it may not necessarily be a big reduction in cost initially, because there's still some of the old patterns of use going to the urgent care or emergency department. And then on top of it, we're adding the community paramedic visits. And what we've seen in our programs is that also then is driving increased visits to primary care. That may be just not necessarily just chewing up primary care doc's capacity, but it might be meeting with their pharmacist at the clinic, or going in for a screening test, so getting the right people connected to their screening for colon cancer or whatever, so that the utilization actually goes up or shifts, and that can include a slight rise in cost. And then after that, you start to see some of the benefit of healthier utilization, and then the costs start to go down over time. But the initial cost can go up, and our experience has been that. So not a great solution if someone's looking to save a quick buck, in the next 6 to 12 months.
I think this is a good visual for that. And this actually is data from the MSSP group, so that Medicare shared savings, who again, as you run the list, there's a theme throughout that palliative is a very strong approach within certain populations. Determining or correlating why patients are readmitting at times can be uncomfortable. It's led to the fact that at times length of stay is more associated to that, refusal of various post-acute care environments, etc. So with this population, our goal is really to get in and help make sure that they're living in the right environment, and that whether or not they need to be in a more assisted environment. And if they've met with the palliative care team to determine, is there a need to continue following lipids, or do we, move off of certain meds, and so really it's this major kind of cultural change, I would say, and that's it's been smooth for the paramedics to have those conversations. I think they're able to really put it into context for patients who have dealt with their heart failure exacerbation at 3 a.m., and the paramedic has dealt with that as well. And so it's a really unique skill set that we bring in that's unique to our position. It's tough to explain to someone, post CPAP, what this really was like for this person in their home. So I think the reduction decrease that we've seen here can be associated to the kind of reactive emergent mindset that we bring into the home. And so just that downward trend of hospital admits is really beneficial. And we use what's called a Coleman model, or Dr. Eric Coleman out of Colorado. Something definitely worth reading. Loads of resources that are available. And so we'll go out and do medication reconciliation and discussion on empowering the patient to figure out how to call the clinic, which can be an absolute pain in the ass to do if you've ever done it yourself, how to schedule their visit, how to find their transportation. So a lot of basic things. And then more importantly, or equally important, to discuss the symptomology of their heart failure, to discuss how to react to the leg swelling, things like that. So it's great. It's kind of bringing this care coordination, community health worker mindset / here's my medical skill set, and then really handing those patients off to the care coordinators and the community health workers to keep a consistent variable throughout their care. And then I apologize. So here, this is pre-enrollment MSSP on the left, 644.7. 2014, 710.5 shows this is the year we were first introduced to them. So we're measuring the following year's impact on that. And we saw a significant reduction here throughout different sets. This is a small set of about 80 patients. We just kept looking at it through different lenses and found some very similar numbers. And then how that breaks down to PM, which is a per member per month. So essentially a total cost of care. We've got plenty of acronyms to go around. And just monitoring again. The uptick in their spend is related to introduction to MSSP. They were a risky patient, and what did we see with that patient? And then what other tools were taken out of the kit within that time frame? Medication therapy management pharmacist, behavioral health, social worker, or psychologist, and again figuring out amongst those, who and why made the impact to see the reduction. So I think we're going to wrap up for some questions, and I'll let Dr. Tanguy as well. And any questions at all that come up later on, there's emails and phone numbers. You're more than welcome to call. Anything else to add?
No, I think in preparation for this talk, one of the kind of frontiers that I think I've underappreciated is the palliative care component. I think we're really good at starting that conversation and helping people facilitate, but I think that there's a good opportunity for community paramedics to get the more knowledge we can gain in palliative care, the better we're going to be able to serve our patients and function within an ACO type model for sure.
Okay, everyone, we're going to unmute your line so you can ask questions live. 1 second.
The conference has been unmuted.
Any questions for Pete or Pete? Pete, there's a question in the chat box. Do you want to grab that?
How do CPs work with partners? Yeah. You want to take that other, Pete?
Yeah, so my answer will go back a couple of years to when CPs first came out in Minnesota. I think there was some a fair amount of questions, and Gary, you can speak to this too, but the home nurses, I think some home nurses feeling like community paramedics could be stepping on their turf or taking away work from them. I know I had a lot of conversations with the heads of some of the home health agencies where the community paramedic program was working. What we were able to show, though, is number one, by our mission, we weren't there to replace home health. And so if a patient qualified for home health, our initial approach was to say, nope, that's your patient, you take care of them. What we've found now in the last year is that I think the threat has been addressed. No one feels threatened. and what we're finding is there's a lot of opportunity to collaborate. So number one, the community medics are, I go back to one of my favorite patient referrals to a home health agency for their chemical dependency. And the patient came back before my shift even ended in the ED. And when I called the home health company, they said that patient wasn't appropriate because there was drug paraphernalia and alcohol in their house where they lived. And that was the exact reason that I'd sent them or referred them to home health. So I think the community medics have been able to show that they're able to function in a wider variety of settings, especially settings where home care doesn't meet the requirement or can't work. And then what's been really exciting is the home care agencies, when they realize that someone's eligibility is running out, but the patient's still vulnerable, the times that the home care agencies refer to the community paramedic to pick up that patient or monitor the patient, that's been really cool. And then vice versa, when the CPs have been able to go out or identify when someone's eligibility changes and now becomes a candidate for home health. So to me, I think that the initial thing is threat, potentially, but then through work, it really becomes a good partnership with the home nurses and our home nurse colleagues.
Yeah,
and
Gary,
go ahead, Gary.
I would just add in that when we did our legislation in Minnesota, we had a difficult time with the nurses. Ultimately, though, we're coming up on a decade of community paramedics working in Minnesota. The first class was in 2007, and no nurse has lost a job yet. And they've sort of figured out that we do work together and work nicely with them. One other thing I'd like to say is we just finished the 12th annual IRCP meeting in Saskatoon. Davis Patterson was on with us earlier, but he had to drop off. He did a nice presentation at IRCP about that included data for the rural community paramedic programs in the United States. And he's got a nice slide that shows where referrals come from and where they go to, and there's a real nice balance between community paramedics in rural areas getting referrals from home health agencies and also referring patients back to home health agencies. And so people have sort of figured out that Medicare pays for the first 100 days, but the patient may not be done with home care after 100 days, and there's sort of a gap there, catching them on the front end, catching them after hours. There are some sweet partnerships. So if you're interested in some of that data about where they come from and where they go to in terms of the rural parts of the country, if you go to www.ircp, that's short for International Roundtable on Community Paramedicine.info, and then click on meetings, and then click on 2016, you'll see all the presentations from Saskatoon on the left-hand side of that web page, and streaming video is on the right. So if you find Davis Patterson's on the right side, you can actually watch him give his presentation over streaming video. Anybody have any other questions? Okay, well, Pete, there was a ton of information here. Thank you for doing this. We appreciate it. We'll have a core group that couldn't make it today that will watch over the internet. Just lastly, I'd add in that in addition to Davis Patterson's video on the IRCP website, there are 30 other presentations. 25% of them are research related, and there's one randomized controlled trial. So feel free to look around and see what you find interesting, and spend some time there if you like. And I haven't heard from Kevin what's up for next month, but I'm sure he's got something special for us again next month, and we'll hope to have you all back again then. So thanks, everybody, for joining.
Yeah, thank you.
Thanks.
Really appreciate it. Goodbye.